Good morning, good afternoon, and good evening, everyone. Thank you so much for joining our ZIP webinar, CSOs in Immunization, a framework to navigate multi-level barriers. I'm Chantal McGill with Core Group, and before we begin, I'll go over some housekeeping instructions. In terms of housekeeping, interpretation is available in English and in French. To access it, click the globe icon at the bottom of your Zoom window and select your language. Please feel free to introduce yourself in the chat, your name, organization, and country, so we know who is joining us. During the webinar, you'll be invited to take part in quick polls. When the time comes, you'll be notified and the poll panel will appear on your screen. If you have questions during the session, use the Q&A button at the bottom of your screen. It may be in the More menu if you are on a laptop or mobile. That way we can track and respond more efficiently. If you prefer to ask your question live, feel free to use the raise hand button. To use emojis or the raise hand button during this session, click the heart-shaped reaction button at the bottom of your screen. Now in French, information pratique, un service d'interprétation simultanée est disponible en anglais et en français. Pour y accéder, veuillez cliquer sur l'icône représentant un globe au bas de votre fenêtre Zoom, puis sélectionnez la langue de votre choix. N'hésitez pas à vous présenter dans le chat en indiquant votre nom, organisation et pays, afin que nous sachions qui est avec nous aujourd'hui. Au cours du webinaire, vous serez invité à répondre à 2 courts sondages. Lorsque le moment sera venu, une notification vous en informera et le panneau du sondage s'affichera à l'écran. Si vous avez des questions durant la session, merci d'utiliser le bouton Q&A en bas de votre écran ou dans le menu Plus si vous êtes sur mobile, ce qui vous permettra d'y répondre plus efficacement. Si vous préférez poser votre question à l'oral, cliquez simplement sur le bouton Lever la main. Pour utiliser des emojis ou lever la main pendant la session, cliquez sur le bouton Réaction en forme de cœur en bas de votre écran. Once again, good morning, good afternoon, and good evening, everyone. Thank you so much for joining the webinar, CSOs in Immunization, a framework to navigate multi-level barriers. Our agenda today includes opening remarks by our wonderful moderator, Dr. Folake Olayinka, expert presentations from Gavi and ZIP implementers in Cameroon and Nigeria, a dedicated Q&A time for you to ask questions and share your thoughts, and closing remarks from Lisa Hilme, Core Group's Executive Director. Now, it's a pleasure to introduce our expert moderator, Dr. Folake Olayinka. Dr. Folake Olayinka is a respected global health leader and immunization specialist with nearly 30 years' experience addressing complex public health challenges. Her work spans immunization, polio eradication, maternal and child health, and infectious disease. In addition to serving as the immunization lead at the United States Agency for International Development in Washington, D.C., she has also held multiple leadership roles, including at WHO and IA 2030. Thank you so much, Dr. Olayinka, for sharing your time and insight with us today as a moderator, and I will turn it over to you.
Chantal, thank you so much for the warm welcome. Thank you and introduction. So I'd like to welcome all our participants today, and I'm so pleased to get this timely webinar underway, continuing to focus on reaching children, zero-dose children and under-immunized children, wherever they are, with full vaccination, particularly in mixed communities, in fragile, conflict, and humanitarian settings. Today's focus on civil society organizations working on immunization and a framework to navigate the multi-level barriers that they face. It's going to be really rich and exciting. The role of civil society organizations is becoming more important as we grapple with longstanding and new challenges in reaching immunization goals. CSO's role in immunization has grown over time, from a primary focus on demand generation and social mobilization to broader roles in several aspects of immunization. In recognition of the important role of civil society in immunization and primary healthcare, Gavi, the Vaccine Alliance, and civil society organizations have also expanded their partnership over time. In the Gavi 6.0, this partnership becomes even more important as part of Gavi's fragile and humanitarian strategy and approach. The ZIP, Zero Dose Immunization Program, is designed to work in complex settings with communities in emergencies, crises, and unstable environments, and differs from typical civil society immunization activities. We're going to hear more about that today. Civil societies will face multi-level system coordination issues beyond community barriers as they expand their scope in immunization work. The onion metaphor provides a systematic approach to anticipate and address some of these barriers and a way of thinking through solutions. You will hear more about this as well. And now, I would like to introduce the excellent lineup of speakers that we have today. Dr. Amy Radcliffe. Amy Radcliffe is the acting head and senior technical lead for ZIP at Gavi. She has been part of the ZIP management team at Gavi since August 2022, establishing Gavi's approach to grant management and accountability for learning across the ZIP portfolio. We are also so pleased to have with us Dr. Epie Njeme. Epie Njeme is a technical coordinator and immunization expert for the immunization program of the CBC Health Services, ZIP, in Cameroon. He has worked in various roles within CBCHS over the past decade. We are also pleased to introduce Dr. Muknan David Nshie, who currently serves as the country program manager and technical lead for the Gavi-funded Reach Nigeria initiative, providing strategic leadership to identify and vaccinate zero-dose and under-immunized children in underserved communities. And we also so pleased to have Lisa Hilme with us. Lisa Hilme is the executive director of the core group, an experienced nurse, researcher, and global health leader with over 30 years experience working across more than 20 countries. She is recognized for applying rights-based, gender transformative, and community-led approaches to improve the health of women, children, and underserved communities. So with this excellent lineup, I'm going to move to our first speaker, Amy Radcliffe. At any point during today's webinar, please put your questions or comments in the Q&A box at the bottom of your screen. Thank you very much, and over to you, Amy.
Thank you all. Thanks so much for coming. This is a webinar that we've been very excited about putting together. And I'm going to talk about what we call the onion metaphor. And many of you are familiar with the task of peeling an onion. What we have done is applied this to our work within the ZIP project, but really the experience that many of the CSOs, civil society organizations, have had within the work that Gavi has asked them to do. So let's go to the next slide, if we may. So this is setting up Gavi's ZIP humanitarian partnerships. I'm not sure that you all have joined previous webinars, so I'm going to go ahead and give you an introduction to the landscape and the global footprint, or the Africa footprint, of Gavi, recognizing that some of you have heard this before. So in 2022, Gavi set out to make a unique set of awards as 2 regional consortia to work in communities where national programming was impeded or held back by challenges that had to do with either conflict, crisis, or cross-border work, including internal or externally displaced people. So including people who crossed borders or where there were disruptions to populations within a national border. Originally, this work was set out with a consortium led by World Vision in the Sahel or West Africa area, and with International Rescue Committee in the Horn of Africa. Over time, that work has evolved. World Vision ended their contract with Gavi in 2024. And so the shading that you see on this map right now is representative of the current footprint. And I want to point out that this puts Nigeria originally within World Vision and now within International Rescue Committee's award. It also moves Cameroon from being originally in the World Vision Award to an independent award with CBCHS. And what I want to really acknowledge is that both CHAN and CBCHS experienced, therefore, two phases of this work. So working with us under World Vision, and then moving and working in a new format, CHAN with IRC and CBCHS with Gavi's only individual award to a national civil society organization. Let's go to the next slide. As Gavi did this, the aim of this was to really set out awards to humanitarian partners to extend routine and catch-up immunization through humanitarian programming. But what we also were asking the humanitarian partners to do was take on new roles that had not been expected for civil society or even non-governmental organizations in capacities from beginning to end of immunization. So what we were basically saying is, we're not just asking for a demand creation project, we're asking for anything that the National Immunization Program cannot do in this area, please take that on. And this was a very broad scope. It was also, in some ways, a very vague scope, and it meant that the CSOs needed to figure this out on their own, including their relationships with the NIPs. Let's go to the next slide. As we worked through this, we also had another wrinkle or complication that we were experiencing. So ZIP was asking these CSOs to deliver not just routine immunization, but also to deliver catch-up immunization to children up to age 5. And across 11 countries, all of the countries were at different stages in putting together, in acknowledging the big catch-up need that had been associated with the COVID pandemic, but also in enabling catch-up and routine immunization to broader ages. So we were asking as early as December 2022 to immunize children up to age 5 before the Gavi Alliance had even announced the big catch-up and all of the support that would enable that. It was also before each individual country had committed to the big catch-up, set up their strategies, resources, and logistics to do that. So we were effectively asking CSOs to do something that the countries had not yet planned for. And this was frankly disruptive, but it also was an opportunity that we didn't want to miss. Let's go to the next slide. Fast forward now from 2022, when we were setting all this up, to April 2024. We had a ZIP leadership roundtable meeting in Nairobi, Kenya. It was participants were both from IRC and from World Vision. And we sat down to talk through the barriers. In many cases, CSOs work thinking about community level. We often in immunization ask you all or ask NGOs to take on the community level work, the social behavior change, demand creation, enabling resources at communities. But we haven't very frequently asked the CSOs to reach all the way up in terms of even getting access to vaccines, in some cases that couldn't come from the national program. And so we sat down and said, apart from the community, where are the barriers that you're experiencing? And the policies and standards were highlighted as very critical sets of barriers. And we spent a lot of time on them in April of 2024 because they were almost every country had some policies and standards that had been restrictive, whether we had worked through those or not. And in some cases, the policies and standards were so restrictive that catch-up immunization was not possible. Let's go to the next slide. So we started to map these barriers, and we started to look through using the icons that had been on the page before. And we started to look through and say, at what level do these barriers exist? And at what level might we need to apply our coordinated advocacy to help unlock these barriers or unlock the restraints, the restrictions? So we noticed that these were not simply at district level or regional level. They were not even always within the National Ministry of Health. Sometimes they were coming from finance or other ministries. And they were also coming from regional health authorities and recommendations that might have been put together there. And they certainly were coming at the global level from the Gavi Alliance with UNICEF, WHO, and Gavi itself. So let's go to the next slide. And with this, we started to work through these barriers. But as we were working through, we'd get a little bit of progress, and then we'd end up going back. And we realized that we were working through this as though we were peeling an onion. And each layer was also making us cry. Pardon my kind of corny metaphor, but it was really a frustrating experience, and we weren't getting through where we needed to go. So we started to think, what would it look like if we organized ourselves to slice through the onion rather than to take this time peeling through? And hence the metaphor was born. Let's go to the next slide. When we organized the same system, the same ecosystem that you saw on the previous slide with the icons, this is simply the same kind of schematic with a different color signifying the onion, but also showing that when we worked through this and used the leverage from Gavi, the leverage from the national program and the ministry, and also used the leverage from the civil society organizations themselves, we were able to actually think about this all at the same time for the same issues and slice that onion. So let me use an example of how we did that for what was really quite a complex new problem. So next slide. So this is an example of indigo devices. And I want to call your attention to the picture at the bottom where you see the man on the left wearing a backpack. This is a very high technology, but simple science deployed in a very innovative way. These are backpacks that can hold 300 to 500, depending on which kind of vaccines you're carrying and how big the vials are, doses of vaccines that bring the temperature down very quickly using pressure and hold that temperature for up to 5 days. So this allows the vaccines to be transported easily on motorbikes. It also allows the vaccines to be stored at a facility at last mile for up to 5 days. So in 2023, we saw that this was possible, and Global Health Labs is the organization that this was Bill Gates, not the Gates Foundation, had funded all of the research and development for this work, and Global Health Labs was supporting the rollout and support for this. The manufacturing and all of the coordination of this was in different entities, but managed by Global Health Labs. So we started working with them, and they came and piloted in one country, but they did not have pre-qualification from WHO yet. So purchasing these and moving them into countries and even getting the country's support and enthusiasm about these was really not possible until we got to the point of having pre-qualification. Once we ended up then being ready in January 2025, so now pre-qualification had been granted. We budgeted for these in all of the ZIP countries for the International Rescue Committee work. And in January, IRC came to Gavi and said, this may take a long time to work through. And in some countries, it could take 8 months because we now need to move through all the layers of this onion. And we're worried that we're not going to get these devices into the country until the end of the year. Should we cancel? Should we remove these from our budget? So let's move to the next slide. What we decided to do was not keep working through the layers of the onion, but move to a barrier analysis where we mapped these and said, okay, where are the barriers that are most critical? And what we realized in March of 2025, I'm using now the example of Ethiopia, was that the most critical barrier at that stage, Global Health Labs was willing to visit. The Ministry of Health was curious and keen and had seen these devices. But we knew that without tax exemption, this would really get slowed down and could end up that we were unable to ship the devices. So we identified the Ministry of Finance as the most important place for our advocacy. And we needed to speed this up. In May, we set out a very clear, everyone came to a meeting and we all left with our assignments to work through the national approvals, to get the ministry really enthusiastic, but really importantly, to ask the Minister of Health to appeal to the Ministry of Finance. And from May to June, this was approved within 1 month. We got the tax exemptions granted and the devices were cleared for shipment, arrived in country in August. Training was organized by Global Health Labs during the same month that the devices arrived, and they went out to the field. Actually, I think I'm getting that wrong. They went out to the field in August. So let's move to the next slide. So in using this is kind of how this schematic was applied. So we looked and said the tax exemption is the most important piece. But to do that, before we get to requesting tax exemption, we need to get everyone organized with a focus on the Ministry of Health. Because rather than having Gavi ask the Minister of Finance, it needed to be internal. So we focused Gavi, Global Health Labs, and IRC's attention on the Ministry of Health. We were also able to use the opportunity of the World Health Assembly in Geneva to actually meet face-to-face with the Minister of Health from the Gavi country team. So let's go to the next slide. Oh, which is to say, this really shows that while you can use this exact schematic, the metaphor itself was really important. We didn't need a workshop to work all this through. We needed one meeting where we had done some organization to say, it's the Minister of Finance that is most critical. How do we all organize? What are our tasks? And once we brought this framing to the table, we were all able to leave that 1-hour meeting with clear assignments to enable and unlock and allow the Indigo devices to be transported. I'll sign off there. Thank you.
Amy, thank you for really bringing this to life in terms of such a critical way of identifying and thinking through barriers and solutions, moving from peeling slowly one by one to actually cutting across and advancing more quickly. Thank you. Right in front of your screen, you see a poll. So this is where I would like everyone, all the participants, to take a moment to engage with this poll. And this is very quick. We'll have it for 30 seconds. For the English, at what levels have you been most successful in navigating barriers? Select up to 2. So if you can do that quickly, we have that on the screen. And pour nos collègues qui parlent français, à quel niveau avez-vous le mieux réussi à surmonter les obstacles? Choisissez au plus 2 réponses. So you can also take that in the French for our French speakers as well. Merci beaucoup. And we'll just leave this for just 30 seconds. So looking forward to your responses. Okay, 5 seconds. All right, maybe we can take a look at the results and see what you have put. Wonderful. This is a really interesting pattern here. And it's really interesting to see that the levels that you have been most successful in navigating barriers are really around the community and the local health systems. So thank you for that. And this is where a lot of the critical actions need to take place, the delivery and really ensuring the vaccination reaches the child and the missed communities. And we can see also here the if you go through the national and the subnational health systems come in almost at a medium level, and then where you have indicated the least success is around the global health systems and regional. This may reflect probably more where you are working. So maybe we'll just keep that in perspective. Thank you very much for your participation there. Give us some quick insights. I'd like to go to our next speaker, who will take us into a very practical experience of Cameroon and how they also worked with this framework. Dr. Pierre Njeme, over to you.
Thank you very much, Folake. Good morning, good afternoon, good evening, everyone. I'm Epien Jume. I'm the technical coordinator for the ZIP project in Cameroon, and I would like to share, I'm going to share Cameroon's experience rolling out the ZIP program and dealing with some of the issues we encountered, and also reflecting on ways in which we would have probably done things differently vis-a-vis the onion metaphor. Next slide, please. So in Cameroon, in the Northwest and Southwest regions that are majority English-speaking regions, there's been a conflict that has gone on a little for about 10 years now, where separatist groups are fighting to secede from the rest of the country. And this has led to loss of lives, destruction of property, and displacement of people. So people have been displaced both within the country, where people are leaving their communities to join relatives and well-wishers in relatively safer parts of the country. Some have moved out of the country into neighboring Nigeria. In the far north region, as you can see on the map, there's been the Boko Haram insurgency characterized by frequent sporadic attacks within the populations bordering Nigeria. And those two have led to displacements and all forms of violence. And these conflicts have disrupted the health system. Many facilities have been destroyed. Fixed vaccination posts have been destroyed. Supply chain lines have been cut, making it difficult, for example, to maintain and replace broken down cold chain equipment, moving vaccines and supplies from the different stores. The Cameroon Baptist Convention Health Services has been existing since 1936, planted by missionaries from North America, but transitioned to indigenous leadership in the 80s and has metamorphosed into the highest healthcare provider, second only to government. CBCHS services are present all over the country, and we provide services to everyone who needs it as an expression of Christian love. And because of this practice where we reach out and accept everyone irrespective of their political, cultural, or other ideologies, it has earned a level of trust. CBCHS has earned trust within the communities. Perhaps its forte is it's also in the fact that we have presence in the most remote rural locations where there is no other provider. And because this has put CBCHS in a unique position to be able to deliver or roll out the ZIP programming in conflict areas where trust has become a very scarce commodity, but CBCHS still is able to access these communities based on all the things that I've just mentioned. Next slide, please. So CBCHS began rolling out the ZIP programming in 2022, and we began vaccinations in August of 2023. But we quickly realized that despite the fact that we were using human-centered approaches, leveraging our faith and community pathways to reach out to the different sectors in the community, and of course, integrating vaccination within other humanitarian services, we quickly encountered a number of issues. The first one was that vaccinators were not administering vaccines to children aged 12 months and above. And we found this in all the focus areas we were working in, but we were rather taken aback because we knew the catch-up policy allowed for vaccination through 5 years for routine vaccination. So when we checked with the supervisors at the district and regional levels, we were told that we need to get some kind of authorization to vaccinate these children because they are usually considered all cible, that is not within the target population for routine immunization, except during special campaigns. So when we got back to the central API offices, they wrote to the regional and district supervisors, letting them know that they are supposed to implement the catch-up policy the way it is. So fast forward through to September, October, we now printed out catch-up calendars and distributed and then trained vaccinators. But then we encountered another problem. We quickly realized that the data collection tools were not able to capture data for children aged 12 months and older. And so we lobbied and advocated, and different tools were produced that were adequate enough to accommodate data for this age group. And so this is how going through one step after the other, we surmounted this particular challenge. Next slide, please. So just like I mentioned in the previous slides, we had a catch-up policy which was, in place, but it was not operationalized, and there were different issues that I already mentioned. No train, the vaccinators were not trained, and another important aspect was that the catch-up schedule was also very complicated in that it didn't allow measles-containing vaccines to be administered during the first contact. for children aged 12 to 59 months. And it also required a huge gap, a 6-month gap between administering Penta 2 and Penta 3. And this led to lots of children being lost, especially in this fragile context where there are lots of moving parts, and children are always moving about, parents are moving about with their children in search either for shelter or food, and also for security, because in these conflicts areas, the displacements are so random that it's so difficult. It's very difficult to predict, and missing out children. This has lots of impacts, including measles outbreaks, which we actually encountered in some of the districts that were, bordering the districts or the focus areas we're working in. Next slide, please. Now, when we eventually, surmounted that barrier and were able to vaccinate the children, we also ensured that even as we went on to get to the second phase of the project that started this year, in February 2025, we anticipated that since we're working in new districts, we'll probably have the same issues. And so our approach was different in the sense that we're able to already disseminate catch-up printouts of the catch-up calendar, conducted training early, and ensure that the data collection tools were available to capture the data that the vaccinators or the vaccination teams were generating on the field. Next slide, please. If we're to represent the issues that we face with the example I just gave, following the onion metaphor, we would realize that we took several steps, like peeling out each layer of the onion, from getting the authorization to having a simplified catch-up schedule, conducting trainings and campaigns, and educating parents and other beneficiaries on the ages or on the children who are eligible for catch-up vaccination. This took us a lot of time, and in that period we wasted resources, and it's definitely not the efficient way to go. Whereas if we had anticipated, each of these barriers at the different levels, we would have been able to proffer solutions at each of these levels to run concurrently, and that would have enabled us to save time, be more efficient in programming, and also, reach many more children. Next slide, please. Nonetheless, we realized that addressing issues using the onion metaphor is a smart and efficient way to go. And so we are even now with the other issues that we are facing, including finding partners with whom to integrate vaccination services and to deliver an integrated package of care. We are also having issues around humanitarian access negotiation and filling cold chain gaps. And the lesson we have learned is permitting us now to address these issues, not as we did previously, one layer at a time, but reflecting through and anticipating the different issues that would come from even the layers that are not yet visible, so that we can now, provide solutions or come up with solutions that can address these issues, save time, and bring life-saving vaccines to children. Next slide, please. Thank you very much. I'll be happy to take questions.
Thank you so much, Epie and Jume. We're going to go to the poll right now. We're going to take the questions later in the webinar. But please put your questions and comments in the question and answer box at the bottom of your screen. Now, there's a little icon with a question mark. Thank you so much once again, Epie. Right now, I'd love to hear from the participants today. We're so appreciative of your engagement. If you can take a moment to respond to this question on your screen, we will be able to get some more insights. Which levels usually have the most unexpected or challenging barriers for your programs? We want to hear from you about your experiences. Et pour nos collègues participants francophones, à quel niveau rencontrez-vous généralement les obstacles les plus inattendus ou les plus difficiles pour vos programmes? Sélectionnez au plus de réponses. So you can provide either in French or English, and we will give you about 30 seconds to provide your responses. Okay, I'm going to give it 5 more seconds. Okay, can we take a look at the responses? Thank you. Oh, this is really very interesting to see where we're really experience the most unexpected or challenging barriers for your program. I can see here the local health system seems to be where people have indicated as where you're having the unexpected or challenging barriers, followed by the National Ministry of Health. That is very interesting, or the national governments, I would say, and the National Ministry of Health. And also at the community and family level. I think once again, we are seeing a reflection of where a lot of us are working and really bringing the pragmatic and practical approaches to ensure full vaccination takes place. So I really want to thank you all for taking a moment to share your experiences on unexpected or challenging barriers for your program. Thank you. I'm going to take us now to our next presenter, who is going to share experience from Nigeria, Dr. Muknan David Nche. Over to you.
Thank you very much. It has been a very interesting conversation so far. And I want to share the experiences from Nigeria. Thank you, my colleague, Dr. Epie, for sharing the Cameroonian experience. All right, so Nigeria, like many other countries in the sub-Saharan Africa under the ZIP programming, has experienced different levels of conflict in the communities where this work has been implemented. The context in Nigeria, in the northeastern part of Nigeria, is one in which in the ZIP communities where the work is being implemented, they have been impacted by humanitarian emergency and insurgency for over a decade in the northeastern part of Nigeria by different actors, the Boko Haram, the ISWA, and etc. And in that implementation over the period, we have seen a mix of the different challenges from crime and violence in different parts of the country, which are spread from the northeastern part of Nigeria to the northwestern part of Nigeria and even the north central part of Nigeria. And the ZIP programming in Nigeria is implemented through a consortium that initially started with as Race for Sahel in 2022 with World Vision, to now the REACH project, which is led by the IRC REACH consortium, implemented in Sudan, South Sudan, Somalia, Chad, and Nigeria. In Nigeria, the Christian Health Association of Nigeria, which has been existent since 1973, over 50 years, coordinating efforts in over 500 health facilities across the different parts of Nigeria, providing healthcare and public health services, in hard-to-reach remote communities, is the one implementing the project on the ground. And we have enjoyed the trust and social cooperation with community stakeholders, both traditional and religious leaders, enhancing our access to all of these communities as the project was designed and implemented. In these communities, in 9 local governments across 4 states in Nigeria, Borno, Kaduna, Plateau, and Sokoto states, there are varied myriad of challenges that these communities faced. In Borno State, you see a mix of kidnapping, terrorism, and widespread displacement across these communities, where the non-state armed groups, are taking over some of the communities. In Kaduna State, which borders a number of states in Nigeria, and also has the cattle routes, are prone to kidnapping and for ransom and farmer-herder clashes. In Plateau State, it's a mix of ethno-religious crises across the different communities, and also kidnapping. So all of these factors makes it very difficult and challenging for children to access vaccination and for government health system to operate safely or coordinate activities effectively. Next slide, please. So as we reflected on this over the years of implementation, we adopted certain methodology, next slide please, that has helped us to deepen the reach and access children. First is our understanding around the localization of service delivery, where we engage indigenous health workers with high risk appetite. The slide before this, and are able to, as a risk mitigation strategy, engage in the communities and advance immunization services across the communities, building on the trust that have been established, and their understanding of the terrain. We also adapted a sandwich approach where as we are able to access and negotiate for access in these communities, we intensify efforts, on the go, and adaptive programming in all of these places that are also impacted by not just the humanitarian challenges, but also flooding and other climatic shocks. And in doing that, we have been able to access these communities. We were able to also deliver a data-driven monitoring system across these communities, leveraging remote sensing and GIS technology in those communities to track the movement of teams, to assess missing communities, and to be able to monitor real-time the service delivery and provide supervision and feedback as the services are being conducted. As we continued on that strategy, we were able to also deploy a One Health approach, an integrated approach, where in some communities, for example, in Kaduna State, we're able to liaise with other organizations and CSOs to co-deliver services while the team are providing routine immunization services. The other CSOs are also providing immunization for cattle, in that approach. In Sokoto State, a mixed methodology where we're able to also do tree planting as a way of supporting the climatic challenges in those states. As we did that, we achieved all of these successes across that. But then this was not without challenges that the Onion approach helped us to unpack. Next slide, please. We realized that in Nigeria, because of the model, the co-financing model for immunization activities, we see that the policy allows for vaccination of children under 2, and as we began in 2022, we saw the need and the opportunity for vaccinating these children. But there was policy restriction, because of the large number of children in Nigeria and the core financing model. And we began advocacy across, the subnational and national level with the Federal Ministry of Health, and with support from the Gavi, ZIP PMU, and also the Gavi senior management team. to allow for the children above 2 years to be vaccinated. Now, in Nigeria, the policy allows for the children under 2 to be vaccinated. However, MCV was only the vaccine that could be administered for children above 2 years. And so the journey went on with those kinds of challenges as we saw them. But then we now saw the opportunity in the big catch-up conversation that started in 2024, where children above 2 years had access to vaccines, but then posed another challenge. These children could not be vaccinated in the communities and local governments that we have been earmarked for the ZIP implementation. And so another level of advocacy had to take place. And by June of 2025, we were able to secure permission through this partnership to be able to vaccinate children. But then came another level of challenge that just accessing letters and permission does not guarantee the smooth implementation of these strategies in the community. So we have to advocate at the subnational level. And these were some of the challenges that we had to face. But then I'm happy to say that as at September, we have already started vaccination for this age cohort 2 to 5 years in some of the local governments that we support. So next slide, please. So what has the onion exercise taught us? We now saw a myriad of challenge that we could have been peeling from one level of layer to another, but then we saw the opportunity, that the onion exercise opened our eyes to see that whereas the zero-dose child, which is multiply deprived, would be benefiting from routine immunization, there are a layer of challenges that have to be passed. For example, because of the co-financing model in Nigeria, even though the policy conversation had begun, we needed to access vaccines from that model to be able to be given across the different age cohorts in Nigeria. That brought in the conversation with the Gavi Secretariat, the Gavi ZPMU, and the senior country managers. At the national level is to advocate, for the vaccines to be accessible across the 4 states and 9 local governments that the ZIP implementation is being done. And then that also meant that the operational conversation that included access to data tools, access to these vaccines needed to be done. And that was something that we had to undergo. At the subnational level, whereas we received these approvals at the national level, that needed to be communicated so that these age cohorts at the 2 to 5 years are also accessible. At the local level and the subnational, in the local government level and the communities, we needed to deepen the conversation for caregivers to give access to children, the stakeholders, the community leaders, to be able to, create the demand for those immunization services as the children are being accessed. And of course, this helped us to unpack this. So what are the reflections we have to share? Next slide, please. As a country, we see that there are a number of lessons that can be learned from this exercise. Of course, using the onion exercise, we realized that as we did this conversation at the subnational level, we had to have conversations with UNICEF, with the state level, the LGA level, like I discussed earlier, and also deepen the demand generation. Next slide, please. And so what we have been able to achieve and what the onion exercise or the onion metaphor helped us to unpack are lessons across board that we love to share in this webinar. The first is that as we look at the onion tool, the metaphor, the tool helps us to x-ray and unpack the challenges across board, which gives a systematic lens at looking at the challenges that any CSO like us would face as we try to implement this ZIP implementation or any form of routine immunization exercise in the ZIP communities. That it revealed that it is not just a challenge that comes from the communities and families, but it's a challenge that cuts across from the global level, the national level, down to the community level. It helped us to also see that we would have saved time if we had looked at the challenges across the layers, but we had to first start implementation, having to reach those conversations before we revert back, to pushing for those changes to take place. And that also impacted on time and the impact that we would have gotten from the outset. At the end of the day, it also showed that the multiple deprivation that the zero-dose child had, with other challenges around nutrition, around livelihood, are things that other partners within the routine immunization and non-immunization partners can help us to solve as we looked at it. Then finally, the framing of the multiple deprivation for the zero-dose child can be better coordinated when the layers of the challenge are unpacked and are looked through the onion metaphor. Next slide. So we have a few suggestions for partners to look at as you attempt to, to engage in this exercise, in this approach. First is to recognize these barriers early. Applying this metaphor helps not to just look at it from the various different layers from external to internal, but also to look at it across board, analyze and flag risks that exist in this implementation so that changes can be quickly made, and where you need support from other partners, within the space, those can be accessed, and it helps to close the time and for us to be able to access this care for the enormous number of children that need the services and need this care. The other thing that we want to recommend is to communicate across level. And this is to clarify where the barriers do exist and share them with not just the donors and funders, but also have the conversation with the funding mechanism and also with local partners. And having to identify that whereas these antigens would be available, we needed to discuss with the local health authorities to train and retrain health workers and to allow for last mile delivery of these vaccines and access them. The sequence of solution is something that we now saw, and the onion metaphor helped us to see how we can unpack these solutions and kind of apply them in parallel and not wait to do them at the national level and the subnational level. And it also helps us to advocate for the integration of health services as we attempt to look at it from the One Health approach. Very importantly also, as I attempt to round up, is the fact that as we looked at this, it helped us to document the different ways these challenges we have faced and to provide the solutions and also to negotiate within the partnership. And so I'll just stop here and we'll listen for comments and other questions as we go on with the conversation. And thank you, and over.
Dr. Muknan, David and Chair, what a really interesting presentation, sharing your experience in fragile conflict and very complex settings in Nigeria. You really brought a very practical lens on using an onion metaphor in terms of multi-level and multi-sectoral barriers. Thank you very much. Right now, we are going to spend some time taking your questions, and we do have our excellent speakers here who can respond to them. So once again, let me encourage you to use the question and answer box at the bottom of your screen to put any questions you have or comments. So I'd love to invite the speakers to all come on camera. Dr. Muknan, Dr. Epie, and Dr. Amy Ratcliffe, please do come on. And my first question, I can get us started as people are putting more questions here, but my first question would go to Epie and Muknan, David, and this is really in terms of the application of the onion metaphor. Could you say who you found to be the key actors in terms of using the onion approach, and what is the greatest value add that you found in terms of this application with the onion lens and metaphor. Maybe I will throw that to Epie Jume first, and then Mukna David, if you will come after him. Epie.
Okay, thank you very much, Falake, for that question. So, in our experience in Cameroon, we found that the project implementers, supervisors at the NIP supervisors at the regional and district levels were the key actors in terms of stakeholders involved in identifying or co-creating solutions to address the different issues that we raise. But in general, we also found that, especially for the other issues that we are yet to address, that the key players typically would depend on the particular kind of issue at stake. For example, we are in the course of looking at ways of securing humanitarian access into communities that are controlled by non-state armed groups. And so in this case, we realize that in our setting where there is this deep mistrust for public health services and any kind of any service that is related to government, we find that religious leaders, community leaders, and other opinion holders within the communities hold a lot of sway, and they are the main stakeholders in terms of bringing out solutions to the issues. Whereas if we're to address say the cold chain gaps, we'll be looking at the national level, stakeholders at the national level, and also at the international level, including Gavi Alliance partners like the WHO and UNICEF. And in terms of the value add, like I mentioned during the presentation, reflecting over issues following the onion metaphor has really given us an edge and helped us to save time and resources because actually there was a noticeable difference in the way we kickstarted programming in the previous Race for Sahel project and how we did it in this second phase, because we had learned that it's very crucial to reflect over issues and anticipate the different barriers at the different levels and addressing them concurrently. Thank you.
Thank you so much for that. David?
Yes, thank you very much. So in our experience in Nigeria, we find that the onion metaphor was useful for application amongst the program implementation team, looking at the different stakeholders, having to unpack the different layers of challenges and bringing every actor to book, to the conversation table to unpack the different challenges they're facing. And in our case, we reflected across the different levels from the subnational level to the national level and unpacking the challenges. And it was interesting to hear some of the concerns and challenges that we thought may not be significant. So for example, you would see that at the national level, when you reflect and you see that advocating and securing permission with the government for policy allowances for the implementation of this cohort would have been adequate for getting the children vaccinated. The communication of these policy allowances and approvals needed to trickle down to the subnational level and the local government level. And so those levels of understanding of the barriers that do exist was something very significant for us. We also see that as we unpack the conversation around the metaphor, including other stakeholders, other partners that have contribution in routine immunization implementation and designing strategies for immunization in Nigeria would have been also valuable in bringing them in the conversation, say other co-partners or alliance partners, or expanded partners of Gavi into the conversation, so that they also in part contribute to the co-design, the advocacy approaches, and the contextualized delivery of some of these processes that, as it were, we found to be either the levers or the drivers of our successes. In terms of the impact of the metaphor, having gone through, this and implementing for over 3 years in Nigeria, is that first, the metaphor helps us to have a panoramic view of the implementation and not just waiting to unpack the challenges by layer. So you are not waiting to meet a stumbling block before you begin to discuss strategy for overcoming it. But then looking at it, cutting across from external to internal across all the different layers was very useful. And then also just to highlight that it also would have helped us to buy more time, hit the ground running as it were, and also design the strategies with all of the stakeholders bringing their contribution as we begin the implementation. Those are the few things I'd like to say for now. Yeah, thank you.
Thank you for that very clear response. We have another question, and I think this would go to Amy. This question is from Peter Owiti. How is Gavi supporting communities? As mostly from my experience in Kenya, Gavi does not support communities, but only national CSOs and multinationals. Amy, do you want to speak to that?
Yeah, I'd be happy to. So traditionally, Gavi's funding flows only to national immunization programs, to national governments. And one of the things that we have really noticed that the ZIP program was set up to do, but also that we're really integrated within the fragile and humanitarian approach in Gavi 6.0, is a recognition that there are missed communities. There are communities that are missed, not just because of last mile, but for other potentially socio-political reasons. And some of those may be related to conflict and crisis. Gavi has really worked to make sure that we have the ability to help national governments prioritize these communities in different ways with a real equity lens. And so the fragile and humanitarian approach that's rolling out within 6.0 allows a conversation between Gavi and the national programs to make sure that we're identifying those communities that have been missed, where equity is needed, and then to tailor approaches with a differentiated approach to health system strengthening. So in some cases, this will be through local implementing partners, through CSO, either national, or in some cases, accessed through international consortium. We're still working out what those grant models might look like, and that will certainly shape who we make grants with directly, right? But knowing that Gavi's work with communities is always going to be through a service delivery actor, an organization, a civil society organization, or the government that's delivering those services. And so what Gavi is working to do is make sure that we are intentionally directing and targeting those resources to the communities that have been traditionally, for any reasons, left out, either because of last mile or conflict and crisis.
Thank you so much for that, Amy. I'm going to go to the next question, and we have a question here from Vlad Chidad, and the question is, how is the exit strategy looking? Are the various stakeholders of the national health system able to take up vaccinations on their own or need more strengthening? And this is in the context of these fragile conflict and humanitarian settings that we know are often unstable. So I think this is a good question to hear from those that are working within the countries. EPA, do you want to speak to this? And then I don't know if Amy wants to also add anything.
Yeah, thank you, Folake. Thank you very much for that question. So, that's a question that has been going through our minds here in Cameroon as well, and I cannot tell you that we have the answers. Because for us, for example, the conflict is still ongoing, and we don't know if there's an end. There's an end in sight. And unfortunately, where we are currently rolling out the ZIP programming, we are able to administer these vaccines to children, especially the measles containing vaccines. But we also find that in the places where we are not working, there are outbreaks, measles outbreaks. We had a few. We had one health district declared measles epidemic 2 weeks back, and then last week another health district that is bordering the areas where we're working. So this goes to underscore the importance of this particular approach to programming. But it's very challenging to say whether like the NIP is going to be able to take on from where we live, where we would probably stop when the project life ends, because we are yet to see a scenario where people start to trust the government, because accepting vaccines in many of the places we work in Cameroon is along the lines of trust. So people want to trust the person who is providing the vaccines. And for now, we've tried to build a system where, people can safely access our services, including vaccination and other services. But I can assure you that it's a very difficult question to, to provide a very clear response to. Thank you.
Thank you so much, Pierre, especially where you have instability, where things can be ongoing or resurface. And then you also talk about the trust factor. Some of them are issues related to trust in government itself. So thank you for that. David, any reflections, or Amy?
Well, so because the successes thus far has been around the humanitarian approach, I would like to add that lessons are still being shared, but then because of the complexities of the challenges within the ZIP communities, it is difficult to be able to safely, hand over those kinds of communities to the government. But we see opportunities, to continue to share the learnings from the strategies that have been deployed. But then the success, like APA said, is hinged on, the kind of interlocutors, the kind of, sandwich approach that are used, for accessing those communities. And this is something that the broader conversation needs to, keep in view as we reflect on, what's happening in the years to come. Thank you.
Lucky, if I could just add very briefly to that, one of the things that I want participants to hear about these two projects is that these two are exceptional cases where we know that the government would not have the access, that the independence and neutrality that comes from having CHAN and CBCHS delivering is a large part of what makes this work possible. That these are specific communities where government delivery is stretched because of trust, because of access, and because in some cases of security risk. We do have other situations across the portfolio of ZIP, and an example of this is Tigray in Ethiopia, where we're working actively to say, okay, so ZIP has been there. We've built and rebuilt, in many cases, the health immunization system. We've strengthened the functions that need to be there. And we're looking at both a handover for the funding. This is an exceptional pot of money at Gavi that doesn't come out of country ceilings. And so we don't want to spend that money in cases when it should be out of the country's allocation to do this work. And we also don't want to be creating any parallel systems where it would work best to coordinate with governments. But we also don't want to do that prematurely. We don't want to set that handover up and then have crisis or compromise that would then again restrict and cut off access for these communities. So it's really community first, what works best for these communities, and ensuring that the principles of humanitarian programming are brought to bear. Thank you.
Thanks very much, Amy. So another question that has come up is, what humanitarian approaches are critical in reaching zero-dose and under-immunized children? And what are the lessons learned in linking these humanitarian approaches to the immunization programs? David, you spoke quite a bit about this. Do you want to kick us off?
All right, thank you very much. So one key thing to realize in this is that the humanitarian approach, because of the fluidity of these communities, is hinged around the humanitarian principles of neutrality, independence, that deepen the trust and access that we get into these communities. And that said, because of the fragility, there needs to be an approach around adaptiveness to the context. So most of these implementation are context specific, where an adaptive programming and scenario planning is involved. In most of the places where we implement, first in Nigeria, we adopted a localization approach, which was key in getting the communities to trust the service delivery, to layer it on the trust we enjoy between the traditional and faith leaders to gain access to these communities. So that becomes a very key process in gaining access and negotiating for access into these communities. Another approach that we have used to deepen this is the approach around the monitoring and evaluation systems, and what we see is that we use the GIS systems to identify communities and layer in technology to help us identify communities that may have been missed across service delivery processes in the months of implementation. And we've evolved from just the GIS system to remote sensing. So we did that, modifying the traditional IMA framework of identify to now introducing the negotiation into the conversation, to reaching through the bespoke service delivery methodology, where the team members go to the communities, first discussing with the communities, and then where there is access, they advance, and where there is none, they kind of postpone sessions and enshrine those flexibilities into the approaches. Those are some of the strategies that we have used to help us, attain the successes we have. Thank you.
Thank you very much. Epia, do you want to add anything to that?
Yes, Folake, thank you. So to add to what Mugnant said, so in Cameroon, we found that integrating vaccine service delivery within the broader context of other humanitarian services meets the needs of the population in this fragile context. And so we set out to identify other partners that are providing these additional services, including nutrition and wash and the other humanitarian services. And so as part of our programming, currently, we are systematically screening these children for malnutrition. And interestingly, we've been able to, pick up and identify quite a number of children with moderate malnutrition, with whom we have now working with World Food Program have provided food supplements to these children, and children with severe malnutrition, we've referred them to health facilities for appropriate management. So our vaccination teams are also now able to, identify survivors of gender-based violence and, refer them to the different service providers that are available. So we understood that within this context, the populations have multiple needs, and typically vaccines are are very low on the scale of preference in these communities. And so unless we now come up with other services, sometimes they are even not keen to accept immunization unless it's accompanied by other services. Thank you.
APA, and thank you so much for that. I have a question, Amy. This is for you. There are 3 questions that are very similar. We have a question from Yuzukanji, who is asking how to get a partner for implementing the project in Tanzania. We also have similar question from Nanette Barke about DRC. Has Gavi considered including DRC in the ZIP program? And there's a question from Paula Vaz, which is, I'd like to know how Gavi funds ZIP activities in Mozambique. So those 3 questions, and we will end with your responses. Amy, over to you.
So the one thing that we do not have work in Tanzania. We're not considering ZIP at the moment for Tanzania. Again, going back to the premise around fragile and humanitarian programming under the ZIP program. But I would say that the principles and practices of agile delivery, of community-tailored approaches for immunization, and combining routine and catch-up up to age 5 are all really important factors that I would look at as I'm looking at partners. If I were in a different seat, looking at partners for implementation in Tanzania, look at national and local implementers who can take on those abilities, and then also what they need from the national program to make sure that they're sustaining or building that. So again, in that case, we want to make sure that we're always prioritizing the national programming and support to the national program first. We are considering right now 2 different aspects for the ZIP program that I want to make sure that we're sharing very clearly. The first is the ZIP program was seen as Gavi's 5.0 humanitarian partnerships. By 5.0, I'm referring to Gavi's 5th strategy period. We do our planning in 5-year periods. So this was from 2000 to 2025. And that strategic period is winding down now. So as we are working to finish our work under 5.0, that does not mean that we have finished immunization in any capacities for Gavi's work, right? So we're looking at mechanisms and funding pots and being sure that we're being accountable to our board and also our donors. So remember that Gavi is a multilateral organization that receives funding from governments and also philanthropies like the Gates Foundation. So we have an accountability to our donors. So if you will, we're making sure that we're accountable for the successes that we've achieved, but also that we're bridging and building for the future. So we're at a stage right now where we're looking at the programming that's currently happening within ZIP and strategically and responsibly planning for what is needed for that programming going forward. So does that programming need to be within the consolidated cash grant? That would be the country funding that Gavi is working towards with countries. And I've already included Tigray as an example of something that we're looking at with that. But we're also looking at where is ZIP's need, where is the need for ZIP-like programming to be into the future. First of all, I think it's unlikely that it will continue to be called ZIP. So watch this space for a potentially confusing name change in the future. But looking at what that leads us to, and we have right now Mozambique, we also have DRC, we have commitments right now to Nigeria and to Cameroon and to other countries within the portfolio, where we're looking now to say, we're not worried about what we call it. We're worried about making sure that it continues to happen responsibly and with appropriate transitions. The children and babies of today need to continue to have access to the vaccines that get them through their full schedule, but we also need to make commitments to make sure that the children that follow, either as their siblings or eventually 20 years from now as their own children to make sure that we're growing towards the future. So we're making very strategic and careful calculations about how we set this portfolio up. I would ask everyone to look at what they can do now to tailor programming in locations to the communities that need it, to borrow from the humanitarian practices with agility, impartiality, humanity, but also to some degrees independence and neutrality. And then also watch this space to see, as Gavi announces new programming, we're working on very diligently what that's going to look like, and we hope to have news to share on that soon.
Amy, thank you so much for that comprehensive response. I want to just thank all our speakers today for the practical insights in navigating complex immunization systems in very, very difficult contexts and settings with experiences from Cameroon and Nigeria. Thank you, EPA. Thank you so much, Muknan. The presentations and discussions underscore the successful programs require systems thinking that look at multiple levels of barriers as well as cross-cutting issues and really bring a proactive and intentional approach to this. As we heard, many benefits in terms of time, resources saved, and bringing together a host of important stakeholders that are relevant to localized solutions. The onion metaphor reverberated throughout today. Hope you can take that with you. It's really a great approach for anticipating barriers and looking at solutions, and a tool for synchronizing coordination. I heard that a lot, including joint advocacy. I'm still very excited about all I heard today. I hope you are. At this point, I'm going to end my role and hand over to Lisa. Thank you so much for your engagement today. Lisa, over to you.
Thank you so much, Dr. Fulake. On behalf of Core Group, I'd really like to thank all of the participants for coming to today's webinar. You know, without your participation, your questions, your collaboration from all over the world, those perspectives are so important. And we really hope the discussion offered some of those insights and sparked meaningful reflection to take to your programs. I know that you will never think of onions the same again. And again, we cannot, you know, we are just so grateful to extend our thanks to our speakers also and our moderator, sharing their knowledge, their perspectives in very difficult and challenging environments. And it really has been instrumental in deepening our understanding of this critical topic. So thank you, Dr. Fulake. Great moderation as always. Dr. Amy, Dr. Epi, Dr. Muknan, we're so grateful to all of you for sharing and taking your time. I think today, some of the key things that we have heard is in the value of these layered, contextual, sensitive strategies for humanitarian perspectives. We heard about human-centered approaches, working with ministries and adaptability in approaches, as well as leveraging faith-based organizations and using those existing community pathways when available. Catch up is challenging, and hearing about some of the strategies our partners have used has been so valuable. So thank you very much. We're looking forward to you attending our next webinar, which will be focusing on integration in the delivery of full immunization in humanitarian settings. So we'll look at how those integrated approaches enhance immunization services, really spotlighting the effective practices, the coordination models, and the strategies that will promote those equitable access for the children in humanitarian settings. We'll be sharing the webinar and we'll be keeping engaged with you in the future. The presentation and recording and transcript will be very soon shared via email. And so thanks again for all your participation. We're grateful to the ZIP team and to the Core Group team that made this happen. So We wish you continued success and have a great rest of the day or evening. Thank you very much.